When we started treatment, we of course discussed this in a multidisciplinary ward and with all the different specialties, including the nurses and the trial nurses, and sometimes also the GP is present. We discuss this, but the most important point is that we should really stick to a written protocol. It's not a good way to work when you don't have a written protocol, which should be revised every year, for instance, in order to keep it updated and that everybody's sure about their places, what to do, when to do, and at the same time that the patient also knows who is really responsible for the care. Because the patient is seeing different specialties, radiation oncology, but also pulmonology, medical oncology, depending on the country, nurses. And so it's very important that once something happens, who's actually responsible for the whole treatment chain. And that should be discussed in a written protocol and not for every patient alone. When we embark with stage 3 non-small cell lung cancer, we have a variety of coordination, but also specialties, and which should work together for a certain patient. Now, there's different possibilities depending on the path and the treatment what you have to give to patients. Some patients receive concurrent chemotherapy and radiation, some receive it sequentially, and some receive only radiation or with surgery. Now, when it's about concurrent chemoradiation, that's the most complex one. And what should be done is that you give the patient information about radiation, you give the patient information about chemotherapy, but also about the side effects. This is the most important one because concurrent chemoradiation has a mortality of about 3 to 4%, just toxic deaths, mostly due to infection, but sometimes also due to pulmonary embolism. And that's the reason why it's so important that you work really together. Now, practically speaking, again, you have to have a protocol. The protocol should be on paper, of course. The protocol should also be spread not only amongst specialists, but also amongst nurses. It should be clear to the patient and the family of the patient, and that should all be written down. Then we discuss with the patient actually the side effects which could go on, but also with which side effect the patient to go to. So not only who is responsible for the whole chain, but also if you have a specific problem, where should you go to? Because you should go to the least or difficult way. For instance, if a patient, like in the Netherlands, sometimes is living literally 90 or 100 kilometers away, he should first have to go to the GP, for instance. But in certain circumstances, for instance, when you have high fever, it's better to go to the emergency ward. And the emergency ward should not let the patient wait for 3 or 4 hours. Those patients should be seen within, let's say, 20 minutes or so, because otherwise you could die of a sepsis. So all those things should be discussed, but should be clearly written down on paper. And everybody should know the task, and the patient should also know where to go to. The whole team is a very broad team, and we discuss patients in a foreseen multidisciplinary way. We have even more than one a week because we have so many patients with lung cancer. First of all, we should have a written protocol, because without a written protocol, everybody will just shout something that's not good. You should really have a written protocol, which is as much as possible evidence-based, so that we know what to do and how the coordination is. However, you have patients who cannot be defined in a protocol. We have so many different possibilities, including also the diseases where which patients may affect. And therefore, we need to discuss this openly with everybody. And so in our team, I think in a lot of hospitals, you don't only involve the specialists, so like the pulmonologists, like the medical oncologist, the surgeon, the radiation oncologist, the pathologist, but also the nurse. This is certainly important when patients already have some disease like lung emphysema, that you have a nurse, for instance, who follows those patients for a longer period of time. The GP not necessarily physically available, but maybe by Skype or so, something like that, where they can also give some very interesting advice in that sense. And for the elderly patients, we also do an assessment by the geriatrician because of the frailty of the elderly. And elderly starts, that's difficult to define, but something like 75 plus or so is certainly important to keep those people also on board. And then you review it and you try to go for a certain aim for the treatment. And what is more and more often done is also to keep the patient also very actively involved in order to know what exactly the patient is expecting and wanting. For the most younger patient in a general condition, that's very clear, that's cure, the maximal of cure. But for older patients or for patients who are frail, it's not necessarily cure. And so we are developing, like many people do, shared decision tools. That the patient has some tools, most of the time it's web-based, of course, to get informed about the pros and the cons of every possibility in his or her case, and to try to give this information in a way that the patient understands it. So not only percentages, but also what does it mean to have shortness of breath in all situations and so on and so forth. So that's a kind of shared decision making. And that is, of course, for everybody important, but certainly for the old and the frail patient who sometimes says, well, the only thing what I want is, for a year in a fairly good condition, and then for the rest, I don't care. And then, of course, you should not give very aggressive treatments.